I just want to thank everyone for joining us tonight. Our featured speaker tonight for the Equity, Diversity, Inclusion, and Indigenous Health Equity Speaking Series is Dr. Randy Jackson. And tonight we'll be discussing understanding health issues for Two-Spirit and Indigenous LGBTQIA+. Our opening remarks this evening will be provided by Dr. Bernice Downey, the Associate Dean of Indigenous Health at the Faculty of Health Sciences. And Dr. Bernice Downey is an Anishinaabe Tea woman of Ojibwe and Sioux Sioux and Celtic heritage, a mother and a grandmother. She's a former nurse, a medical anthropologist, and is currently cross-appointed with the Department of Psychology, Psychiatry, and Neurobehavioral Sciences, and the School of Nursing in the Faculty of Health Sciences at McMaster University. She's also recently been appointed as the inaugural Associate Dean of Indigenous Health for the Faculty of Health Sciences. Her research interests include health literacy and Indigenous traditional knowledge, and health research system reform for Indigenous populations. She currently holds a Heart and Stroke Foundation Canada Institute of Health Research Chair in Indigenous Women's Heart and Brain Health. She is committed to addressing anti-Indigenous racism and the promotion of Indigenous self-determining approaches in health equity and system reform. So thank you very much, Dr. Downey, for joining us. And Dr. Randy Jackson, please take it away.
Well, miigwech, thank you, Whitney, for that introduction. I'm very honored to be asked to in an introduction of my colleague. I'm also the co-chair of the Equity, Diversity, Inclusion, and Indigenous Reconciliation Advisory Committee. So I'm really pleased. Our speaker series have been fantastic so far, if I say so myself. The series was designed as an educational one that explores issues related to EDI and Indigenous health in an interprofessional, safe, and interactive environment. The series explores topics that can have significant implications in the care of patients, treatment of research participants, and interactions in the educational environment. The goal is to provide faculty, staff, and learners a holistic understanding of EDI and Indigenous health issues and their impact in the clinical, research, and educational environments. This fall-winter 2021 series focuses on two LGBTQIA+ positive spaces in care, and the first sessions focused on building positive spaces and allyship. A panel discussion was held in November with members of the Faculty of Health Science to discuss healthcare for this group. And today, my colleague, Dr. Randy Jackson, will present health issues relating to Two-Spirit and Indigenous LGBTQIA+ individuals. So when we think about this issue, it's important to note that the human rights of all persons are universal and indivisible. Everyone should enjoy the same fundamental human rights, regardless of their sexual orientation and their gender identity and expression. Around the globe, people experience violence and discrimination because of their sexual orientation or gender identity or expression. LGBTQ2I people experience discrimination and harassment in housing, the workplace, and the classroom. They are also often victims of hate-motivated violence, including physical attacks, arbitrary arrest, torture, sexual assault, and murder. From an Indigenous perspective, our two-spirited youth and other children were routinely sexually, physically, emotionally, mentally, and physically abused. The pain that they endure still resonates today. And while traditionally two-spirited people were respected and valued, these views have often been replaced by homophobia and internalized racism as a result of church doctrines and assimilation that accompanied colonizing processes by settler governments. And so before we begin this, session by Dr. Jackson. I would like to acknowledge that McMaster University recognizes and acknowledges that it is located on the traditional territories of the Mississauga and the Haudenosaunee nations and within the lands protected by the Dish with One Spoon Wampum Agreement. So without further ado, I would like to introduce Dr. Randy Jackson. Dr. Jackson is an assistant professor in the School of Social Work here at McMaster with a joint appointment in the Department of Health, Aging, and Society. He is originally from Kettle and Stony Point First Nations, which is Anishinaabe Nation, and he explores lived experience among Indigenous peoples living with HIV and AIDS, IPHAS, using Indigenous knowledge, perspectives, and values. Dr. Jackson is the nominated principal investigator of and co-leading with Renee Mashing, the Feast Center for Indigenous STBBI Research. His program of research explores the use of Indigenous knowledge across diverse topics, including, for example, experiences of depression, Indigenous masculinity, Indigenous trans health, Two-Spirit resilience, and Indigenous peoples living with HIV leadership. Randy is the recipient of a Queen Elizabeth II Diamond Jubilee Medal in 2012 and a CAN-FAR CAHR Award 2020 for excellence in his community-based research work in HIV with Indigenous peoples. He's a very active member of our faculty here at McMaster, recently completed an academic co-chair leadership role, and is very, he's an amazing individual, friend, and colleague. Please welcome Dr. Jackson.
Thanks, Bernice. That was very nice of you to say all that about me. Appreciate it. So just a little bit about that photo there. That was a photo I took at probably about 12 years ago at a powwow in my home community. And I just love the image of it. So I'm going to be talking about, as others have already said, understanding health for Two-Spirit and Indigenous LGBTQ+. I just want to start by also giving an acknowledgement. This presentation is on the traditional territories of the Haudenosaunee and Anishinaabe, and within the lands protected by the Dish of One Spoon Wampum Agreement. And the reason we do this is because it's part of the oral tradition. It conveys a sense of belonging and comfort. But I think the best land acknowledgements also leave you with something to think about. So I'm going to ask you to think about who's benefiting from this presentation and why, and how can we collectively work together for more positive change. So I'm been asked to talk about these four broad areas. So I'm going to briefly define and discuss Two-Spirit roles and identity. I'm going to talk a bit about the impact of colonization, and particularly the idea of gender violence. And then I'm going to draw on some of my past research, particularly TUSHALS, which is the Two-Spirit HIV Wellness and Longevity Study, and more recent thinking around this idea that pivots what we talk about when we talk about resilience. So we're going to pivot that and describe it as a gift from the Creator, something that we're born with, and this is what we call a strong mind in English. And then finally, I'm going to address the idea of cultural safety, and I'll talk about the HIV care cascade and the importance of decolonizing approaches to providing care and support. And so this suggests to you that I have a caveat, and I've come to and learned about these ideas through my research program, which is largely focused on Indigenous people confronting challenges of living with HIV. And so I hope that perhaps this is useful for thinking more broadly about the health and wellness of Indigenous peoples more broadly, all right? But before I go any further, I want to also, you'll notice that I have this artwork as part of my slides. And I love this artwork, right? Because for me, it's an influence of George Viner's work in the post-Indian warrior, and it's a focus on Indigenous survivorance. So we understand this artwork as being Indigenous self-expression. It's meant to tell a story that inserts us as an active presence. It's a continuation, it's not an ending. And they renunciate domination, tragedy, and victimhood. And in some respects, you might want to think about this artwork as decolonizing towards a focus on cultural strength. And it builds on an idea that art is a pathway to healing. And I just put here a website that you might want to explore when you have more time. Before I go any further, I just want to stop for a moment and talk a little bit about who Two-Spirit are. It's actually an identity that's quite complex. It encompasses both sexual and gender identities. And so the Canadian Community Health Survey, it was one of the first surveys that asked the question about sexual orientation. And in that study, about 1.7% of Canadians between the ages of 18 and 59 reported a gay or lesbian identity. And about 1.3% reported bisexual identity, and less than 1% reported transgendered identity. And so when we look at identity in the context of behavior, and we know this from a number of studies, and they're listed there on the slide, but when we talk about behavior, a smaller proportion of people will report sexual minority behavior. And so this suggests that people are more willing or more likely to answer questions around identity than about behavior. So Two-Spirit identity was a term that was first coined by the Indigenous members of the LGBTQ plus community in Winnipeg back in probably, I think it was around 1990 or so, a meeting in Winnipeg where this term started to emerge. And the term was really meant to transcend sort of Western and colonial ideas about gender and sexuality, and in ways and I'd say this because it challenges sort of the gender binary of male female, and it actually talks about a third gender, and that third gender, Two-Spirit, is used to describe someone who possesses both masculine and feminine spirits. And some individuals who identify as Two-Spirit only identify as Two-Spirit rather than LGBTQ plus, right? And so what this tells us is that perhaps there's more acceptance of non-binary gender fluidity in Two-Spirit context than outside of that. So the term, it's really important that we understand that the term Two-Spirit is not interchangeable with LGBTQ. These are two separate things. And Two-Spirit is really about enacting sort of the spiritual responsibilities that the role traditionally had. And what I mean by this is this idea of walking the red road, being there for people, giving of oneself, and being a guiding force with this strong mind that one was born for in terms of the gifts that the Creator give. And so the Two-Spirit road is then focused on these long-held traditions of prayer and responsibility, right? It's about giving the highest honor of respect. And when we do that, it's about giving selflessly of oneself to the community in ways that are focused on the health, wellness, and survival of the Indigenous community. So the Two-Spirit people in the past had significant roles, traditional roles that were part of tribal community structures, and many Two-Spirit people will attest to being visionary seers or medicine people, etc. Right? So the Two-Spirit identity is not the same as colonizers' language. right? Again, there's more comfort with ideas of gender fluidity. There's an acknowledgement um, that two-spirit sits on this continuum of gender identity and expression as well. And so two-spirit is also only a term that's appropriate for Indigenous peoples. If you don't have a tribe, it's a role, it's something that one can't claim otherwise. And it's also really important to understand at the outset that two-spirits people experience what's typically called as compounded or layered trauma, right? So two-spirit people often have experiences of homophobia that leads to things like internalized shame. There's gender violence, such as the erasure of two-spirit identity. For example, when many individuals were enrolled in or actually apprehended and taken away from their home and community, they were assigned a gender in residential schools, for example, and that when we push back against some of this erasure, it actually provokes more additional violence. And again, also another area of trauma is racism and structural disadvantage, and this idea that this hasn't ended, that colonialism, the things that led to this colonialism, is still ongoing, and these areas of trauma continue to be experienced by two-spirit people. But before moving forward, I think I want to spend a few slides to talk about Indigenous brilliance and success. I believe that, strongly believe that it's an important Indigenous decolonizing strategy. It's a focus on two-spirit cultural strengths and that emerge in ways that challenges the language of Western scientific and medical discourse, that perhaps offers some justification for continued paternalism and colonialism, bolstered by the idea that I'm just here to help. But perhaps I think a scientific language can also be used to ignore suffering in dispassionate, rational, and objective ways. And in doing so, perhaps if we contribute to this, we unwittingly then ally ourselves to those interests, to the interests of those in power. And that is scientific and medical language can help maintain colonial power and privilege at the cost of doing continued violence to Indigenous people. In fact, O'Neill, Redding, and Leader shared with us that portraits of Indigenous sickness and misery can act and often act as powerful social instruments for the construction of Indigenous identity. Epidemiological knowledge about incidence and distribution of diseases, construct an understanding of Indigenous society that reinforce unequal power relationships. It's language that can perhaps supports the notion that I'm only here to help you, that you're unable to help yourselves. And in fact, when we are taught about Western science and medical knowledge, that strife and challenges are the only thing of value to explore about Indigenous people, we actually do a disservice. The beauty of our essence as Indigenous people become blurred or is hidden from view in these ideas that are only focused on pathologizing two-spirit and Indigenous people. In other words, perhaps through the language of science and medicine, we only ever get to see images of sick and disorganized communities that can be then used to justify, as I said, these continuing patterns of colonialism and paternalism. And I want to talk a little bit about work that I did with a couple of colleagues of mine, Doris Pelche and Errol Nalgesic, because after collective years together of listening to and writing about these kinds of descriptions about the health of Indigenous people, we started to ask the following questions. When it comes to, and we all identify as Anishinaabe, so when it comes to Anishinaabe people who live with HIV, Who gets to decide what living with HIV means? Is it the researchers who have the authority to define us through our illnesses? Is it physicians and nurses? Is it ourselves? Perhaps we already know the answer to some of these questions, right? But according to Cook Lynn, scientific research, medical discourse is often what we would call the dominant master narrative, and it has the ability to powerfully shape Indigenous lives that is based on likely, not likely, is based on an arrogance that is unremittent and that often leads to distortion. So, in attempting to think through some of this, we were inspired by George Weisner's work, as I already talked about, right? And particularly his idea of survivorance and the post-Indian warrior. As we understand them, these terms that express a form of resistance, a form of self-determination. Survivorance means survival with endurance by inserting as a form of resistance new images of Indigenous people that are decidedly post-Indian. In other words, to be a post-Indian warrior, it is to challenge dominant colonial representations of Indigenous people. And I hope to do some of that today. So as I shared today, I hope to theorize some of this back and connect it to what I want to talk about today. And so in order to do that, I'm going to draw on a different study that I was involved in, the Two-Spirit HIV Wellness and Longevity Study that was part of it was, yeah, anyways, I'm just going to continue on here. But before I do that, I just want to give some quick acknowledgements. It was CIHR who funded us for the initial work that we did. We later went to the Ontario HIV Treatment Network, who funded the development of a knowledge translation and exchange website, which I'm going to show you again today. And these were our research team: David Brennan, Art Sokol, and Tony Nobis. And we had several research staff, including Earl Nalgesic, Shaziva Brett, and George Javisky. We also had an advisory committee including people from 4 different community organizations, all of which are considered leaders in the HIV movement here in Canada, or providing care to Indigenous people. And we were really inspired by this idea that this was the early inspiration, right? And so Indigenous people, we knew, were disproportionately represented in Canada. According to the Canadian HIV surveillance report, of all new HIV cases with known races and ethnicity information, approximately just slightly less than 2,200 or 2,100, or sorry, 1,200, slightly less than that. About 19.3% were reported as Indigenous. So this is this is disproportionate representation when we think about that Indigenous people only comprise about 4.9% of the Canadian population. And as I said earlier, too, colonization continues to have an impact on Indigenous people. And so we know, for example, that for Indigenous people, there's often a later diagnosis. So Indigenous people tend to be diagnosed with HIV much later in the course of the illness. There's also this slower uptake of treatment. And of course, this is thought to align with the idea that there is higher morbidity and mortality that's experienced by Indigenous people vis-a-vis non-Indigenous people. And so we thought initially that these were useful, right? These descriptions of Indigenous health were useful, but we also understood that it was just a partial description, right? Again, it paints this picture of suffering and dysfunction. It constructs Indigenous identity and it shapes responses. Again, it can be used to justify paternalism and ongoing colonialism with this idea that I'm here to help. And when we come in and try to be of service to Indigenous people, we need to be very mindful that we're not ignoring principles of self-determination. Again, when we were designing this study too, there was very little to no information about Indigenous resiliency from within an Indigenous worldview. And so that's why we have Two Shawls. And Two Shawls was really built on early work by our community partners around how to resist racism, homophobia, colonization, and gender violence against Two-Spirit people. This is work that they had done in the past. They have a couple of community studies that they ran, and these were considered sort of unique experiences around challenges that Two-Spirit men who live long term with HIV face. And rather than designing research that explored ways of getting people into treatment, for example, what our community partners asked us was, how do we design services that support Two-Spirit's men's health and their resiliency? So again, we started by going to the literature, right? And what we found was this Western understanding of resiliency, where resiliency is commonly understood as positive adaptation despite adversity. And a number of Indigenous scholars and allied scholars have criticized this definition as placing the responsibility to be resilient upon the individual, and that it lacked sensitivity to social and cultural contexts. And so we started to wonder, what does resiliency look like in Indigenous context? And what we found in the literature was this idea that cultural resiliency is connected to sort of broader Indigenous sociocultural environments in which people live their lives. In other words, community is a quite important idea when we're talking about resilience. In this sense, we can think about resilience as being relational. And so resilience is not about an individual's capacity to cope with adversity, but it's about the capacity of a person's community to provide health resources that nurture and sustain well-being. And so typically what this means is access to and use of elders and traditional healers, use of ceremony and spiritual practices, and as well, your friends, family, peers, and community are extremely important. But we also know that resiliency is methodologically really very difficult to study. And so how do you dance around, for example, this idea that some Indigenous people have experienced enculturation? So it's difficult to separate out those parts, Indigenous or cultural resiliency, along with cultural enculturation, to determine whether or not resiliency is more influenced by Western or by Western conceptualizations of what it means to be strong. And so this context set the stage for the questions that we asked, the goal that we set for ourselves, which was really about how can we understand the factors, skills, resources, knowledges, and practices that contribute to Two-Spirit men's health and well-being living long-term with HIV. So we conducted a comprehensive scope and review of the literature that focused, and also we did some focus groups with Two-Spirit men. So how did we do this? The scope and review, again, was this rapid gathering of literature in a given policy or clinical area. And we wanted to assess the evidence and where our current understanding was, and to map these results. And we also did the scope and review in ways that were attentive to how other researchers use decolonizing and Indigenous methodologies, and we were attentive to that simply because we wanted to do future research in this area. And then we did focus groups with Two-Spirit men that, of course, were re-envisioned as sharing circles, adapted and made culturally sensitive to Two-Spirit men. So I'm just going to take you through sort of the findings of the scoping review that we've done. We followed Ernst O'Malley's scoping review process, where we clarified our research questions, we searched for relevant studies, we developed inclusion criteria, we charted the data, and we collated and summarizing the results. And we used in vivo and thematic analysis to come up with some of the findings of our study. And then we took this back, we took our research design back to the Community Advisory Board and consulted with them to make sure that we were on the right track. And we came up with a range of search terms that we used to scope a number of databases. And so once we came up to this inclusion criteria, right? So we wanted to make sure that there was a focus on Indigenous people, that the article that we included would address Two-Spirit, gay, bisexual, and transgendered issues, and that a component of the article addressed intersections of living with HIV for 2 years or more. And we wanted to make sure that we had articles that were talking about resiliency in the broadest sense, from wellness, coping, and strength. So we wanted to make sure that we were including articles for that. And so we as I said, we scoped the literature, and we looked in 12 databases, and you can see the numbers in the chart here. I'm not going to go through all of that, but I'm just going to let you know that in the final selection, we ended up including 21 articles. And from that 21 articles, we started to look at sort of what did we understand about challenges to resilience. And we came up with these 5 categories: structural risks, where impact the way in which individuals could be or are resilient, right? And this was related to a lack of education, experiences of poverty, for example, trauma and colonialism. Multiple minority status was also an issue that challenges resiliency. And this was a layered, as I said earlier, a layered sort of experience. Racism, homophobia, trans and non-binary phobias were often talked about in the literature. One's mental health status could be a challenge to resilience. Other categories like sex works and sex abuse could be challenges to resilience. And of course, there are important differences between rural and urban. And there's some debate about which is more important. Clearly, there are more services that are more health services and support services often offered in urban environments, but in rural environments, perhaps there's more ready access to sort of community cultural supports as well. We were also focused on sort of enablers of resilience, and we found again this in 21 articles. These ideas: group and individual therapy, social support, accessing cultural resources, accessing health services that had some component of cultural competency was really important. Culturally grounded interventions, which I'll talk about a bit later, these were also really important. And it was important to generate information about resiliency using decolonizing Indigenous methodologies. And this was something that was talked about in 11 articles that thought this was an extremely important thing in order to better understand. Now I'm going to talk a little bit about the sharing circles here. And so again, we use this community-based design, and when we weaved in there decolonizing Indigenous methodologies, We had recruitment assistance provided by our two community partners, OHAS and the Two-Spirit people of the First Nation. And we did these focus groups. We had 3 of them that involved, that we re-envisioned as sharing circles. And we had a total of 14 Two-Spirit male participants who acknowledged living with HIV for 10 years or longer. And so again, we held focus group or sharing circles in Hamilton, Toronto, and Ottawa. And we asked one question in those sharing circles: what's allowing you to live long-term with HIV? We provided honorariums, auto-recorded, and verbatim transcripts. And so the focus groups or the sharing circles were moderated by a Two-Spirit man living with HIV and a traditional helper. So none of the research team were present except for our research coordinator who took care of logistics. But the sharing circle itself was again moderated by these 2 people. And we decided very early on to use traditional and ancestral knowledge that reflected oral culture. And so we decided to draw on this idea of symbol-based inquiry. So we created this medicine map or medicine wheel, and you can see it in the photo there. And that was in the center on the floor during the sharing circle. And our hope was that it would elicit dialogue about strengths, assets, and resiliency. And so again, we conducted these sharing circles, asking that one question, and we had ethical review provided by the University of Toronto, as well as McMaster University. And our analysis involved several stages, and we used the medicine wheel. And we used the medicine wheel because it expresses this notion of all my relations, an important symbol in Anishinaabe culture that we felt was representative of the way of the Indigenous worldview or the Anishinaabe worldview. And we coded the data, qualitatively quoted the data, and the quotes, we selected key quotes out of each of the interviews, and we mapped those key quotes onto the medicine wheel in ways that were aligned with the teachings of the medicine wheel. And we did this in about 3 rounds, right? And so towards the end, we started to find that we started to take our findings to our community advisory committee. But I just wanted to show you a little bit about what this analysis looked like. Again, it was participatory. We had about 80 codes, and that produced some 5 meta themes, right? And so team members read each of the transcripts. The most meaningful quotes were selected from those transcripts. And these were later mapped to the medicine wheel. So we had an elder come in and give us the teachings of the medicine wheel and helped us to understand where things belong in the medicine wheel with respect to our transcripts. But quotes that were difficult to map to the medicine wheel were discussed at a team level. And this allowed the team to balance research needs while foregrounding the holistic relational worldview that used Indigenous knowledge. And so I'm just going to switch here and talk a little bit about the findings that we had. So again, these were all Two-Spirit men who were living with HIV for 10 years or more. The majority of them identified as First Nation, and we had 2 Métis people involved. The age range was between 32 years living with HIV and 61 years living with HIV. And 2 people didn't want to give their age. And in the final analysis, once we got through all that coding onto the medicine wheel, what we came up with, what we called 7 truths of resiliency for Two-Spirit men living long-term with HIV. And I just want to spend a little bit of time talking about that. I'm just looking for my notes here. Okay. All right. So I just want to start by telling you that the petroglyph on the left is once we were finished all the coding, once we fleshed out all our themes in detail, we handed this off to Earth Lore in Ottawa. This is a multimedia company in Earth Lore, and they had an artist read through our transcripts, and not our transcripts, but read through our interpretation of the transcripts. And this is an artistic interpretation of each of the truths or paths to resiliency that were part of our study, right? And the first one that I want to talk about is worldview. And so what we believe about the world is extremely important. And cultural beliefs and values about the world influence our participants' description of living well with HIV. For many, good health is aligned with the idea of striving to achieve balance among the physical, emotional, mental, and spiritual aspects of the self. Right? Indigenous worldviews are considered fundamental to living well, and many participants provided sophisticated descriptions that recognize value in balancing the holistic aspects of the self. It is a focus that supported participants to develop as mentally strong, emotionally present, physically healthy, and as spiritually grounded persons. Here, participants often reference the cultural resources provided by their communities, such as connection with other Two-Spirit men, seeking guidance from elders, and making concerted efforts through ceremony connect with their spiritual worlds. And here, one participant shared, I see balance in all of those things. The power of the Indigenous worldview guided participants to overcome challenges and to think about their wellness journeys as connected to community cultural strengths. Our second truth of resilience was this idea of finding one's strength, and that it's important to accept and work with challenges in a good way. So, connected to worldview, the theme of finding one's strengths was centered on efforts participants made coming to terms, self acceptance with their identities and life circumstances. And what I'm referring to here is being gay, being gender diverse, living with HIV, and Indigenous persons being Indigenous more generally. And they describe that being honest with themselves, of being vulnerable and open with significant others in their lives, and self-acceptance was necessary for living well. And as one participant described, it's part of why I'm a unique individual I am, and now it probably is my most cherished possession, my unique sexuality. Finding one's strength was described as firmly connected in community relationships, and as a result, being able to much more easily navigate life challenges in more efficient ways and growing as an individual. The third truth, again, this idea of walking towards balance, and it's these are our action statement. That was one of the things that came very clear to me when we were doing this study is that much of these are about action, right? So, like the Indigenous teaching, All My Relation, participants describe walking towards balance as expressing an active sense of individual agency, and this was considered by them to be integral to developing resiliency. Here, social support was considered fundamental. Through the walk, though the walk towards balance was often conceptualized as an individual one, many participants also described deep connections with family, friends, and community as being equally important. As one participant shared, that's what I love about the HIV community. It's one big family. We have the one thing that connects us all, and that's HIV. The fourth theme. For many participants, recognizing one's true power hinged on being mentally, emotionally, and spiritually ready to hear the positive things about themselves as seen through the eyes of others. And here one participant described, it's about learning to keep one's eyes open, becoming more honest, open, and vulnerable with others, and mobilizing this new way of being to inspire self-acceptance. Another participant described, it's like my whole life I've been trying to learn how to love myself, and I'm there now. Towards achieving this, many participants recognize the power of also connecting to the natural environment. And I'm talking here about the land as being the best form of therapy that one could engage in. And this, of course, is facilitated by through experience and often experiences with, again, friends, family, community, and one's nation. The fifth truth is this idea of Mina Badatsuin. Again, this is the journey to living a good life. It's a Anishinaabe word. And this was talked about by participants as a journey rather than a destination, right? And as one participant in the quote describes it, living a good life is about cultivating personal space in one's life for recovery and healing. And although difficult to define, Mina Badatsuin for many participants was about recognizing one's true power, living one's truth, and is a place of personal growth and of cultivating the mental, emotional, physical, and spiritual resources and strength that one needs in order to live a good life. So many of our participants felt that striving for Mino Debatsuin contributed to their sense of well-being and resiliency. And speaking of the mental aspects of self, many participants shared ways that they were taking responsibility for their own personal healing and growing by attending to this idea of Mina Badatsuin. And they talked about using humor and laughter as effective coping mechanisms. They described how they became active, involved in its Two-Spirit health movement. They touched on the importance of intimate others, family, and community that were considered, again, necessary for living the good life. Self-care for participants was broadly defined as extending beyond the individual to encompass also family, community, and nation. It's an orientation to life where participants described how their actions in the present, while drawing on traditional knowledge, could potentially benefit generations to come. It was expressed as an active sense of this idea of all my relations, of acknowledging how one is ultimately connected, draws on, and supports all of creation, and how this supports the individual in return. Like recognizing one's true power, as one participant shared about being out in nature, it helps just to accept who we are and then move on and move forward. Our last truth, living our truth, was for many participants about being the person who the Creator always meant us to be. And it was described by our participants as we are living our truth, right? And this sense of becoming full circle, of embodying and living comfortably with their full selves, included also their sexual and gender identities, their HIV status, their indigeneity were really, really central and important. And ultimately, living our truth drew on traditional teachings that were expressed as an imperative. And it was through laughter and expressions of joy that were deployed by participants as mechanisms to connect to their health and to their community. And as one participant described it, I need to learn to love myself. And I knew that if I didn't know how to love myself, that my dislike of myself would kill me. And I started to learn how to love me. I love my two-spiritness. I love my gayness. And that was what one participant shared with us. So I just want to stop here and say that we rarely hear about resiliency occurring in the lives of two-spirit men living long-term with HIV. And in fact, I think this is probably one of the first studies where it's received this much focus. It's important to understand that resiliency is not about sort of linear progression through the truth I just talked about, but rather individuals can often locate themselves in one of the truths and use the truth as a guide or a map to living well. Resiliency is also grounded in values and perspectives of one cultures, and it's also about acting on those values and cultures. I wanted to show you this visualization of the seven truths, but I'm just going to pass it by. But there's the website here, and it goes through all of the truths I just talked about, including the data that's connected to each of the truths that I just also talked about. I just want to say too that there were some limits to what I've talked about, including the small sample size, only 14 people. Typically, this is an issue in qualitative research, but it is a relatively small sample size. There was an underrepresentation of Inuit and Métis people, and of course, it was Ontario focused. And we privileged Anishinaabe knowledge in the design method and analysis in the study because 3 of the investigators on the team were Anishinaabe. And I just want to talk here about this, what we think is a necessary pivot, this need to talk about two shawls and resilience in sort of different kinds of way. And in this, we began to tangle with this idea of strong mind. And it was inspired by, in a report back session to community about the two shawl findings, a guy in the audience stood up and said very bluntly, I never wanted to be resilient in the first place, right? And this caused us to pause for a moment and reflect on what that meant, right? Never wanted to be resilient in the first place. But it did suggest this need to pivot away from sort of Western defined resiliency as bouncing back or positive adaptation, et cetera, right? And rather, what we need to do moving forward is to reconceptualize resiliency through an Indigenous lens and what that might look like. And so we recently published a paper on this idea of strong mind, because it draws attention to the strength and power of the Indigenous collective and to cultural knowledges. And it opens up the possibility that we might not focus on what's wrong with people, but on their strengths. And so when we talk about a strong mind, we're talking about this as a gift from the Creator, something that's cultivated, nourished in ceremony with other Two-Spirit people, right? And so to embody a strong mind then is to live one's authentic self with a clear vision, to unmask, to untangle challenges through ceremony. And it's probably best developed and maintained as a land-based cultural tradition through ceremonial practices. And so that was two shawls. And I'm just going to pivot here and then talk about a little bit more about cultural safety and Two-Spirit people. But I'm going to do this through what we call the Indigenous Peoples HIV Care Cascade. And I'm looking at the time and I'm hoping I save enough time for questions. But we have here the what we call the HIV cascade of care. And this helps focus our attention on best practices towards responding to HIV by outlining stages of care. And viral suppression of HIV is a key goal towards, and the key goal here is to end the HIV pandemic by the year 2030. So it's quite an ambitious target. But these targets suggest to us is that Two-Spirit man, Indigenous people, need to have knowledge of their HIV status. They need to be linked to and retained in care, and they need to initiate and adhere to antiretroviral treatments. And so this is the HIV cascade of care, and the 90-90-90 UN AIDS is part of the global HIV agenda. And it's really about making sure that everyone has equal access to care, including 90% of all people being not diagnosed. 90% of those people will be on antiretroviral treatment for HIV, and 90% of those people will have their HIV to be virally suppressed. And such an approach, however, has unique implications for Two-Spirit people that speak to the importance of the need to decolonize this framework. So, in terms of lack of access to, like, for example, there are barriers at each stage of this cascade of care, including poor access to services, lack of HIV education, stigma and discrimination impact, poverty, food security, homelessness, mental health, and substance use. These are all things that are faced by Indigenous people today that might impact the way in which they participate in this HIV cascaded care. And as a result, there's a substantial disconnect between the priorities of the HIV cascade, sorry, and the experiences of individuals, Indigenous individuals living with HIV. And so I'm going to talk here about the need to decolonize. And the need to decolonize is quite evident when we think about systematic oppression and culturally unsafe prevention and care services. And when we think about decolonizing the cascade, the HIV care cascade, we really are talking about healthcare settings that are free of racism and discrimination. We want health settings that are appreciative of Indigenous perspectives on health and wellness, and that those things are respected. We need to tangle with Western services need to tangle with the idea of colonization and how that's continuing and how that's still impactful for Indigenous people. And we need care providers who are humble and self-reflective. It's really, really, really incredibly important that we acknowledge that colonial trauma has not ended, that there's significant intergenerational trauma that continues, racism, socioeconomic disadvantage, as well as pervasive health disparities. And again, these things are important. And then when we think about decolonizing the HIV cascade of care and about Indigenous engagement in this, there are probably six sort of determinants that determine this. Right. The first, of course, is a focus on identity, culture, and ceremony. We need to focus here in terms of mobilizing these ideas as a source of strength and well-being for Indigenous people. We need to understand, like I've shared in my very early story, when I was positioning myself, that an HIV diagnosis can prompt a learning or reclaiming that's focused on spirituality and traditional healing. And when we focus on Indigenous culture, that might help us to come to terms with a diagnosis and provide a model for successful living. And it's important to recognize that many Indigenous people who live with HIV will integrate traditional and allopathic approaches to health. And oftentimes, care providers, and I'm talking here about nurses and doctors and social workers, et cetera, they're often talked about by Indigenous people living with HIV as second family members. So it's important to understand that care is relational in that sense, and to understand too that colonization continues to hamper the uptake of ceremonies and cultural practices. The second indicator, of course, is strength, resiliency, and determination, right? Deciding to fight back against HIV is a deliberate decision that people make. And this is often facilitated by acknowledging one's responsibilities in the community or in life, right? I care for a child, family, I care for an elder, volunteering in the HIV movement, many of the things you heard about when I was talking about two shawls. And so it becomes an important source of self-worth and well-being that mobilizes engagement and care. And people end up building from and centering these cultural strengths rather than on their weaknesses. The third idea is social support systems, right? And a circle of care. So having others around you who can help you navigate living with HIV is really important. And by that, I mean offering tangible, affirmational, and spiritual supports. Where support is, again, is often conceptualized by Indigenous people as reciprocal. So Indigenous people who live with HIV also have responsibilities. And when we enact those responsibilities, this results in increased self-worth and positive identity formation and maintenance. The fourth idea about engagement and care is understanding historical intergenerational lifetime trauma as fundamental determinants of HIV infection, as well as other disparities in health, and acknowledging that colonization or colonialism is a critical element that we need to address for healing and to facilitate sustained engagement and care. Because when we don't, these can act as a barrier to ongoing engagement. And again, this will impact self-worth. Stigma and discrimination, also extremely important. So again, many people, and we know this. I mean, this has been in the news quite a bit, right? So reports of racism, experience of discrimination by healthcare providers, by family, by friends, and by community, all can negatively impact engagement and care. Oftentimes, stigma and discrimination are things that are layered, or there are multiple layers and intersections with that. So it's important to understand it's just not about being HIV positive. It could be about your Indigenous identity. It could be about things like substance use, or it could be about your sexual and gender identity, or even your spirituality. So it's important to understand the layering that individuals experience when they come into care. But again, stigma and discrimination, very, very important to address, right? Because this will lead some people to avoid accessing services, or leads some to access sort of Indigenous specific or gender specific or HIV specific services if they're available. And again, looking at sort of intersecting health concerns, right? So mental health, as you can tell from the HIV cascade of care, is not something that's adequately addressed there. But again, it's important to spend some time focused on that. I'm looking at the time and I'm going to skip through a few slides. Sorry about that. But what these slides are really talking about are just unpacking again, sort of that the three moments in the HIV cascade of care, and talking about ways in which one might address some of that. So I'm just going to sort of end here by saying it's really, really important. And I hope that I've managed to do this adequately with you. But we must leave space that cultivates sort of deep listening and appreciation, right? Do we perceive beauty? Do we stop to appreciate it? Do we recognize beauty in unexpected places or spaces? And do we actively search it out when we don't readily see it? Do we actively search out beauty and strength in ways that are balanced against sort of the broader socio-structural challenges that impact Two-Spirit people and Indigenous health? Right. And that we need to develop a language that emphasizes and foregrounds Indigenous reality, that crafts sort of program and policy responses that are appreciating of Indigenous ways of being and Indigenous ways of knowing. And again, we need to also focus on this need to decolonize the HIV care the cascade of care. So acknowledge colonialism, localized testing and diagnosis, improved access to culturally appropriate care and services, and of course, providing targeted program for Two-Spirit, Indigenous trans, Indigenous non-binary, for example. Here is my contact information, and I think the slides are going to be made available by a recording, I think. And I just want to end with these parting words. Burn sage, burn sweetgrass, burn sacred tobacco, burn the Indian Act. And I don't know who the author was, but I loved it when I saw it.